colleagues and my dear colleague. I am Dr. Simanta Das, working in Guwahati Refinery Hospital, Guwahati, Assam. Today, I want to highlight few updates in hypertension. As per WHO, nearly 63% of total death in India are due to non-communicable diseases, of which 27% are attributed to CVD, which affects 45% people in the age group 40 to 69. Raised blood pressure is among the most important risk factors for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. And to highlight the following points, number one, in India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in men and 1 in 5 in men and 1 in 4 women with hypertension worldwide. International Society of Hypertension, ISH, has released the ISH 2020 Global Hypertension Practice Guideline. The inclusion of optimal essential treatment paradigm attempts to address the issue that in resource-poor settings, optimal care referred to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. Number two, American Heart Association American College of Cardiology has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low-risk adults with no ASCVD, atherosclerotic coronary vascular disease, or 10 years CVD risk less than 10%, with stage 1 hypertension, that is blood pressure between 130 to 39 systolic and 80 to 89 diastolic mm of mercury. Management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacologic therapy. Number 3, acute respiratory distress syndrome, ARDS, is a potentially fatal condition involving lung damage. An expert often associated it with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Number 4, lowering systolic blood pressure target down to 110 or less than 103 mm substantially severe adverse events in STEP randomized trial, offering sprint findings for an older sinus population. Among some 8,500 patients aged between 60 to 80 years in China, the intensive target trimmed 26% of the composite CVDs. Findings from now a second major trial supporting a lower target could unite the guideline, which even among US professional societies range from threshold of 130 to 150 mm of mercury. Number 4. Number 5. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guideline on the Management of Arterial Hypertension recommended the diagnosis of hypertension should not only be dependent on office BP measurements, but also on out of office measurement, such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime blood pressure measurements were associated with greater risks of mortality and composite of severe outcome. Thus, they may be considered as the most relevant measurement for estimating CVDs. For every 20 by 10 mm of mercury increment of BP measured at night, the risk of mortality increased by 23%. The risk of cardiovascular events by 36%. Number 6. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guideline equally recommend 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guideline recommend, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of AC1 or ARB plus CCB or diuretics. Number 7. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is detection of a known carcinogen, namely N-nitro sodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients have been received NDMA contaminated valsartan from Zhejiang manufacturing, that is the manufacturing site where the highest level of contaminated were found. Every day for 6 years in the highest dose, it could result in 12 additional liver cancers over the lifetime of this patient. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visit of plus 6%. Number 8. The highest study represents largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The Hygia chronotherapy trial tested whether nighttime therapy in comparison to upon awakening hypertension therapy exert a favorable CV risk reduction. The latest study included a total number of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BB measurement was performed for 48 hours to collect data how BP differed during sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared with evening treatment. Thank you.